Hello, and welcome to the WPC virtual webinar series. My name is Eli Pollard. I'm the Executive Director at the World Parkinson Coalition. And this program has been a long time coming, starting back in 2019 at the 5th World Parkinson Congress in Kyoto, Japan. There were a lot of conversations about resources and services for people with young onset Parkinson's disease. And that conversation seeded this idea for a course. We actually took that information in 2019 and offered a live in-person pre-Congress course at the 6th World Parkinson Congress in Barcelona, Spain in 2023. There were a lot of people who could not join us in person in Barcelona, and they let us know that they really wanted access to these courses. And so, because of their requests and because of interest within the community, we are now offering this course live virtually for everyone to access. So it's important to note that this entire program is being offered 9 talks in all. They were all designed by people with Parkinson's, particularly people with young onset Parkinson's, designed for other people with YOPD or people who want to learn about YOPD issues. You're going to hear this week about a wide range of topics, from parenting in Parkinson's to exercise in Parkinson's to when and how to make a disclosure about your diagnosis. The topics are wide and varied, and our faculty are true leaders in the Parkinson's world, with 20 faculty members. 12 of them are people who actually live with young onset Parkinson's disease themselves. Other faculty are care partners, movement disorder doctors, we have a nurse, we have a physical therapist, and others. It's really an incredible lineup, and you're in for a great treat. And if you miss a session, don't worry, we're recording them all, and they will be available for viewing as archive talks in the coming week. I want to thank Mitsubishi Tanabe Pharma America for supporting the WPC and bringing this program to you. We would not be here today without their support. So thank you, Mitsubishi Tanabe Pharma America. And lastly, I want to thank our faculty for sharing their knowledge, their experience, their expertise, and to all of you for joining us today and for supporting the WPC and our work throughout the year. Thank you, and enjoy the session.
Hello, everyone, and welcome to the World Parkinson Coalition's virtual YOPD program. My name is Rune Wete, and I will try my very best to be your moderator for the next hour. And I'm joined by Glenn Pentone, who is presenting our session today, which is on cognition and mental health. How are you today, Glenn?
Thank you.
Yeah.
Good.
We are both pleased to have you join us. If you're not already aware, the 9 talks in this virtual YOPD series each fall under one of 3 categories. It's the individual track and the in relation track and the medical track. If you miss a session this week, no worries, because we are recording them and they will be available by Monday next week for viewing. Yeah. During the session, you will notice a box on the right side of the screen with 3 tabs: a question tab, and a resource tab, and a poll tab. There's a possibility of leaving your questions during the whole session. Just be aware that if you make your screen a full screen, which might be recommendable during this session, the question tab will not be there, so you have to leave your full screen to enter the question tab. Just like a pro tip for you. Yeah. So I also want to thank the World Parkinson Coalition for making this possible, and I want to thank Eli Pollard for being the engine of bringing this YOPD forward, these sessions. And of course, I want to thank our sponsor, the Mitsubishi Tanabe Pharma America, for making this possible, and we would not be here today without their generous support. So, with no further ado, I'll just leave the scene to you, Glenn. There you go.
Let me share my screen here. Okay. There we go. Hopefully you can see that. Right. So these are slides that were originally conceived in Barcelona at the last World Parkinson Congress. This year's, of course, will be in May in Phoenix, Arizona. And today, what I'd like to talk to you about is cognition and mental health in young onset Parkinson's. And it'll overlap a little bit with some of the topics you heard about today. So many of you may have attended the exercise and wellness talk earlier today. And so there'll be elements of that incorporated here as well. So in terms of the objectives, I'd like you to become familiar with the presentation of cognitive and mental symptoms in Parkinson's. We'll discuss and talk about how the biological aspects of Parkinson's might be associated with these cognitive and psychiatric issues. And then, I'll recommend some strategies for managing these symptoms in day-to-day life, more so focusing on things that you can do rather than the medications that your physicians may prescribe. And so the first thing I think is important to realize is there's a lot of heterogeneity or variability in the presentation of Parkinson's disease. And Parkinson's is really in a family of diseases that involve alpha-synuclein. And all of these diseases have variable degrees of movement problems, cognitive impairment, and mental health symptoms, okay? And so that variability occurs between diseases, but also within diseases. So sometimes, people with Parkinson's will have a little bit of cognitive impairment. Sometimes they'll have more. And, categorically, diseases like dementia with Lewy bodies that also involve synuclein start out with a lot more cognitive problems, and the motor symptoms are more of a sidecar. And so I think it's important to understand that the variability probably comes from this pathology and the extent of it. Okay, so I just wanted to sort of introduce that concept because, people often compare themselves to other people with Parkinson's and they worry, about symptoms they may see in another. And these are symptoms that sometimes they may never have or may have to a lesser degree. And so the first thing that is important here is that the diagnosis of Parkinson's is still a clinical diagnosis. And this has implications about the psychology of accepting the diagnosis. In most of medicine, we can give you more objective markers of disease. We can draw your blood and tell you that you have the presence of a disease, or maybe even the severity of the change that the disease brings based on objective markers, right? Well, in Parkinson's, we're getting closer, but for the most part, we still diagnose it just by assessing your movement. And then, you have this lifelong condition. And so in many cases, that can be unsatisfying. Now, I will say that we're developing biomarkers like the skin biopsy and the DAT scan that support the diagnosis, and this can help bring the diagnosis a more concrete presence and give you some reassurance. Now, a lot of the symptoms that I'm going to talk about today actually come from parts of the brain that are outside of the substantia nigra. Okay, so when we talk about movement symptoms, a lot of that comes from the dopamine depletion that happens in the substantia nigra pars compacta. A lot of the symptoms that I'll talk about today, the changes in executive function and memory and mood, probably come from other areas of the brain. And so collectively, we call these extranigral because they're outside of the substantia nigra. Okay. And it's important to know that the disease and a lot of these alpha-synucleinopathies produce symptoms like autonomic dysfunction, cognitive changes, and mood changes by affecting structures outside of the midbrain and the substantia nigra. Now, especially, I think, with young onset Parkinson's, a new diagnosis brings a lot of psychological challenge. And so what happens to you after you get the diagnosis, right? So you walk into your doctor's office. For most people, it could just be, tapping their fingers, stomping their feet, and a 10-minute exam. For others, maybe they get confirmation with a biomarker, but either way, there's a lot of stress, right? Because the assumptions you've made about your future and the way your future would play out, at least in terms of your health status, are radically changed by this diagnosis, right? Whether it's severe or mild, slowly progressing or rapidly progressing, your assumption about the future changes, okay? And at that point, you either accept the diagnosis, and by that I don't mean enjoy it or bring it into the family. What I mean is you sort of accept the implications and start changing your assumptive world and plans to meet the demands and challenges of the disease, or you live in some degree of denial. And we'll talk a little bit about that. This uncertainty about the future may make you consider changes to both family life or career. And then as you consider these changes, even before you've actually experienced any substantive change in terms of your abilities, right? You experience maybe loss and grief about what you could potentially lose. And so this can be a really traumatic time, especially because it's at a stage of life where you're probably still in the middle of your career, raising a family. And so it's different than the more typical onset when you're later in life and you sort of already gotten through those challenges of life. And so what happens when people are in denial? It's a very common reaction, and I think most people have at least some degree of denial. And to some degree, it's okay. You might seek a second opinion. You might say, well, look, this guy had me in there for 10, or woman, doctor had me in there for 10, 15 minutes, and they give me this diagnosis. They didn't take my blood. They didn't, do any scan the day of. So you might get a second opinion, and this is absolutely appropriate. If nothing else, it gives you peace of mind. But in more extreme cases of denial, it might result in a delayed time to the initiation of treatment, which can sort of alter your functional status needlessly. So what we know now is that people who start treatment at the appropriate time experience a better quality of life. The other thing that's a risk for denial is that you might pursue other unnecessary workups or even be diagnosed with something that isn't appropriate and have exposure to treatments that aren't necessary. And again, I've seen this over the 20 years or so that I've been working in the Parkinson's space. In some cases, it's not common, but it's something that I think you have to be aware of. Like I said, there's an appropriate level of denial and sort of confidence in the diagnosis. And then there's a point where in order to go forward successfully, you need to sort of accept the diagnosis. And this is a challenge. Now, the other thing that happens with a new diagnosis, especially when people are young, is that the symptoms might not be obvious every day and might not interfere every day. And the neurologists have classically, it's changing, but have classically really focused almost exclusively on the movement symptoms of the disease and dopamine replacement. And they've paid much less attention to the psychological and social implications of the disease. And as we've just talked about, I think that's especially important in young onset because you're changing the assumptions about your future. And it would be really great to have some guidance about this, either directly from the neurologist or from the allied professionals that work with the neurologist. And I think, over the next few days, you're going to hear lectures, or you're going to have the ability to hear lectures about how to navigate this. The other problem, at least with the US healthcare system, is that the follow-up after you're diagnosed can be 6 or more months after the initial visit when you're diagnosed. So you're sort of sitting there, maybe you're trying carbidopa, levodopa, but you might have a lot of unanswered questions or anxiety. And so there's many challenges here. And so when we talk to people who have this experience, who have Parkinson's, they report feeling that doctors haven't been sensitive enough about their mental health needs or the psychological changes that happen. And what we know now is that studies show that anxiety and depression often go unrecognized in half of the time. And so people are suffering from these symptoms that are absolutely treatable unnecessarily just because no one asks or they're not screened. Or on the patient side, you're not proactive about bringing them up because maybe you think they're unrelated to the condition, right? The other thing that can happen is people can become demoralized even before they've actually suffered any significant disability because of this anticipation of the disability and the change in their lives. And so this makes people more vulnerable to experience an episode of depression. And that is really important because depression is a game changer in terms of the trajectory of the disease. It renders people much more disabled than they actually should be, and it's reversible. And so one of the things that we really want to encourage people and their families and caregivers to do, not just the physicians and the clinical team, is to recognize the signs of depression. Depression isn't just feeling sad. In fact, we want people to still experience their normal range of emotions. When something sad happens, we want you to experience, low emotions, right? That's normal. And when good things happen, though, we also want you to be able to perk up and be happy. Depression is really a constriction of the emotional range. It's this experience of mostly negative emotions and oftentimes the inability to enjoy things. Okay, and that's called anhedonia. And either a frank reporting of sad or low mood, or even in the absence of a sad mood, the inability or reduced ability to experience pleasure can be a sign of depression. And usually it's accompanied by symptoms that are negative, things like feeling helpless or hopeless or worthless. Anytime someone feels suicidal or as if life isn't worth living, you want to think about depression. A loss of energy and fatigue can oftentimes go along with Parkinson's disease itself, right? You're stiff, it's harder to move, you're moving more slowly. So that can just be a sign of Parkinson's, but it can also be a sign of depression. Sleep can be disrupted when you're depressed. Oftentimes it's insomnia, trouble falling asleep or staying asleep or waking before you'd like to. But sometimes, and this is a minority, you can have a depression where you sleep too much. So you might sleep most of the day, and that's a problem as well. Appetite can often be decreased in depression, and people can lose weight, and this is problematic. The ability to concentrate and focus is negatively affected by depression, but again, is completely reversible. So oftentimes people might think they're experiencing memory problems or cognitive change due to the disease, when really it's just the reversible condition of depression. And that's a really important point because, sometimes people fear the worst, that they're getting dementia or something like that, when really it's just depression. And then very severe depression can actually slow movement or cause what we call psychomotor retardation. And so again, depression is very important to recognize. Oftentimes it's either missed or sometimes even over-endorsed because the symptoms can overlap with the symptoms of Parkinson's. And so oftentimes people experience a masking of their facial expressions where people around them who know them might say, "You look mad," or "You look sad," when really they say, "I feel great," but their facial expressions are just, blunted because of the disease. Sometimes people with Parkinson's will have apathy or be experiencing an off period, and that decreases our participation in activities. And so you can see there's a lot of overlap here. Sometimes levodopa can cause nausea. And so that might decrease appetite, and that can be confused sometimes with the appetite changes of depression or be magnified because you're having both. Sleep fragmentation and medication-induced changes in sleep pattern can happen with Parkinson's, and on and on. And so, what I tell people is, although there's some overlap here, if you're not functioning well, I think it's very reasonable and a proactive thing to do to be screened for depression if you have any concerns that something just isn't right. And the reason for that is one of the largest studies ever conducted in Parkinson's, the Parkinson's Outcome Project, that's basically overseen by the Parkinson's Foundation, took a longitudinal look at the treatments and conditions that produced the best health outcomes in Parkinson's. And what they found is that for anyone with Parkinson's, young onset or otherwise, the impact of depression on quality of life was almost twice that of the movement symptoms. And if you reverse them, people would bounce up to a higher level of functioning, physical functioning, and quality of life. And so again, the reason that this is so important is that while many centers have started actively screening for depression, some don't. And so you want to make sure that if you think you're experiencing these things, to talk, to the people in your care team and make sure you get the right evaluation. Now, let's sort of shift gears and talk a little bit about the way cognition changes. So cognition is sort of a broad term for all the intellectual functions that we might perform in any given day or task. And it's important to know that as we age, there are some changes. And then there are some changes that are abnormal for aging, meaning that they should signal a red flag that this is disease or medication or some other process related. Okay. So let's start with what's expected with aging. So as we age, procedural and semantic memory should be well preserved, at least until the 7th decade. And procedural memory is the memory of how to do things. So, a very typical one is how to ride a bike. You know how they always jokingly say, once you learn to ride a bike, you never forget, right? That's a procedural type process memory. And those are usually well preserved. Another type of memory for meaning or concept is semantic memory. And so concepts your ability to grasp and remember concepts doesn't usually change just as a result of aging. Okay. Vocabulary and general knowledge also remain stable or even improve as we age through the 7th decade. Okay. Visual perception of objects, now this one's really important, actually remains stable, and older people might actually be more accurate in judging distances. Okay. And then language is stable at least until age 70. So the reason this is important is that if you notice, especially changes in any of these, you'd want to bring them to the attention of your doctor because these should stay stable, especially in someone with young onset Parkinson's. Now, what does change with aging? Okay, with aging, all of us experience a problem with focused and divided attention. Okay, and executive functioning, which is our ability to organize, sequence, and plan. And so the combination of attention decreases and executive decline are the reason we always say nobody multitasks well, especially if you have Parkinson's, because it affects the executive domains. Okay, and so these are going to decline with normal aging. Okay, processing speed drops off a little, your reaction time drops off a little with normal aging. Okay. And with advanced age, so beyond the 7th decade, most cognitive domains gradually change. Okay. So now in this context, let's talk about some of the changes that are more typical in Parkinson's and, disease process. So when you look, and this is a figure that is borrowed from Dag Arslan et al. In 2021, and it's the sort of variability in cognitive change in Parkinson's. Remember at the beginning, I talked about the family of diseases that includes Parkinson's, and that there's greater and lesser degrees of cognitive change and motor symptoms and other symptoms. And so with cognitive symptoms, there's a variety of potential trajectories, even within what we call Parkinson's disease. Okay. And so what you can see is that dotted red vertical line is the time of diagnosis. Everything to the left is before you know you have the disease, and everything to the right is after you've been diagnosed. Okay. And so you see that there's some people who more or less experience no or minimal cognitive change for years after being diagnosed, right? That's your shades of green there, right? These people, they might have some motor symptoms and some other symptoms, non-motor symptoms, but more or less their cognition is intact, okay? Then there's these people who, are sort of in the blue bands who are experiencing sort of a progressive, mild cognitive change over the course of the disease. And typically this is on the order of decades, right? So we say that 50% of people by 10 years of diagnosis will have some cognitive change, and then it goes up from there. So this isn't like it's happening over days or weeks or even months for most people. It's years out okay? And it's not everyone, right? So there's these people who are still experiencing very mild or no significant cognitive changes. But then there's an unfortunate few who are in that yellow band who, for whatever reason, experience a more rapid progression toward dementia. Okay. And some of these people, that progression is driven by the Parkinson's process, an alpha-synuclein. And in others, it might be that it's the Parkinson's process and an added variable, like maybe also having Alzheimer's. Okay. We know that Alzheimer's sometimes co-occurs in people with Parkinson's. Now, people with young onset are at lower risk on average for Alzheimer's. So that's at least one mitigating factor in terms of preserving cognition in young onset. Okay, but one other source of variability is that we know, regardless of the trajectory that you're on, a slow progressor, a non-progressor in terms of cognitive decline, some people have a variability of performance and cognition. We've seen people who at one stage of the disease, they're not functioning cognitively as strongly as they were maybe a few years before, but then somehow they bounce out of that. And we don't know if that's through optimization of their medications or health behaviors that they've taken on, or just some cyclical change within the disease. But there are people who will go from mildly impaired and rebound to normal cognitive function and vice versa, even during that trajectory and progress of the disease. And so variability is more the rule than the exception. I think that's important. And so anytime you experience a change, it's good to consult your care team, because there's many times there's answers or things that can be done. Now, the other distinction that I want to make here is this difference between dementia and mild cognitive impairment, and dementia and Alzheimer's. So the first thing is, dementia is, if you think of this on a spectrum, the most severe cognitive change. Okay, dementia is all the way over on the right, the most severe change you can have, to the point where it affects your ability to live independently day to day. Things that you could do independently before you might need help with. Now, most of the time when people hear the term dementia, they think of Alzheimer's, which is sort of like one type or one flavor of dementia. There's many ways to have dementia. There's Alzheimer's dementia, there's Parkinson's related dementia, there's vascular dementia, frontal temporal dementia. The point here is just that dementia in this case is the most severe manifestation of cognitive change, and it affects function. That's probably the biggest distinguisher between dementia and milder cognitive changes, is that it's to the point where it affects your ability to live independently day to day. Now, cognitive impairment, or what we call mild cognitive impairment, is usually a narrower manifestation. So it might only affect one or two domains of cognition, and you can still find ways to work around that or compensate, right? So it doesn't significantly impact your day-to-day function. And I think these concepts are helpful because they sort of define the severity and where you are in that cognitive spectrum. Now, one of the domains of cognition that is most likely to be affected in people who have Parkinson's disease is executive function. And again, as I mentioned earlier, this is trouble with tasks that require you to organize, sequence, or plan. Okay, everything an executive in a company would do. And one of the best ways to illustrate this is to show what happens and the sort of interplay between the cognitive world and the physical performance world. And this is one of my favorite studies of cognition and Parkinson's of all time. And it was really designed to study the influence of task demands. And we call it jokingly the sort of let's have tea study, because they asked participants to carry a tray with a tea set on it from a mock kitchen to a living room. And the study really looked at people who just had mild to moderate Parkinson's, and then 10 people who didn't have Parkinson's. And they had 4 different tasks that they asked people to perform. One was simple walking from a kitchen to a living room in the study setting. And then the next level of the task with increasing complexity was what they called a dual motor. So it had you walk and carry a tray. And then they had what was called a dual cognitive. So you would walk and recall a list of words from memory. And then multiple motor cognitive task, which was walking, carrying the tray with the tea set, and recalling a memory. So you can see that the general findings were for everyone, whether you had Parkinson's or you were just a control, everyone's walking or gait speed decreased as the complexity of the task went up, whether it was two motor components or a motor and cognitive or all of the components together. Task complexity predicted slower walking. Okay. What was really, though, significant was that people who had Parkinson's were much slower than people who did not have it. So it was the demands affect everybody, but they affected people with Parkinson's more. And this is because at baseline, the disease brings more impairment of executive function. And so what the message from this is, we always tell people to be mindful in general, right? That's a new sort of zeitgeist, is to be mindful and to be in the moment. But I think this is especially true in people with Parkinson's. The more you focus on the task at hand, the better you're going to perform, and you're especially vulnerable to the, drop off of multitasking. Okay. Now, memory doesn't change in the majority of people with Parkinson's. In fact, we think maybe a third or fewer of people with Parkinson's will have significant memory changes. And even when memory changes, if it's due exclusively to Parkinson's, it changes in a way that's different than what you expect in other memory diseases like Alzheimer's. And so the way I like to talk about this is in comparison to Alzheimer's, which is our quintessential disease affecting memory. And so if you think of the process of forming a memory as similar to storing information in a file cabinet, I think it's a good example. And so basically, when you want to store information in a file cabinet, you need first to have the intact information. So maybe it's 6 pages of information, and you're going to put that in a file, and the file maybe has a letter to it. So it's A, B, C, D, E, and you put the file in. And then you close the file, and then at some later point, you want to recall the memory, right? So you have to go back to the file cabinet and open it up. You have to go to the correct file and pull, hopefully, the intact information out of the file. Okay. So that process we call encoding. That's putting it into the file cabinet. And then retrieval is when you go back later to recall the memory. Retrieval is when you withdraw it. Okay. And this is actually a multi-step process. Even though we think of memory as one thing, it's a multi-step process. And so in people who have Alzheimer's disease, they really have a primary problem with new learning. And so they have trouble encoding. So when they have new information to put in that file cabinet, it's corrupted in some way and never makes it into the file cabinet, or at least never makes it into the file cabinet intact. And so whether they're freely recalling the memory, or they just have to recognize something they've seen before, or recognize a conversation they've had earlier in the day, they don't. And so you can see the double down arrows, whether it's asking them to freely recall, hey, what did we talk about earlier today? Or you say, hey, do you remember what Sally told you this morning? In either case, they don't. Whereas if you have Parkinson's, for the most part, you encode perfectly well, right? You go over to the file cabinet, whatever the information is, you put all 6 pages in. And so when someone says, do you remember what we talked about this morning? Most of the time, you can freely recall the conversation from the morning. But sometimes you might have a little trouble retrieving. And so they can cue you. They say, what did Sally tell you this morning? And so that cue, that hint about the context might then bring you to recall the intact memory. Okay. And so you benefit from cueing. And so this is a really important aspect of the way memory changes in Parkinson's. And I think it means too that the way you interact when you have Parkinson's means that the information is most often still there, and it might just mean that you need time or contextual cues to bring that memory to the forefront. Okay. Now, if you notice, if you're a person who has Parkinson's and you notice that these things are completely gone, that's another time when you might want to talk to your care team, because there might be more than just Parkinson's going on. Now, what do you look for in day-to-day function? Obviously in clinical practice, we have tests that we can do, sophisticated memory tests that can elicit these symptoms, or tests that can, tax executive function. But what are you looking for in day-to-day life that would tip you off to be evaluated or to bring this to the attention of your doctor? And so some of the things are, very obvious. So with memory loss, it's repeating the same comment or question again and again, forgetting conversations, difficulty learning new information. So we often see this when people move to a new place and they just have trouble acclimating because they can't remember where this room is or where the guest center is in a new complex if they've moved. Difficulty performing familiar tasks. Remember, we said with aging that procedural memory is intact. So if they're no longer able to use a remote control or microwave or computer or either sometimes simpler tools, this can be a sign that something has changed that's beyond what's expected for aging. Okay. Another thing that we see is inability to organize medications. Now, look, with Parkinson's, the regimen is very complicated. It's many times per day, and the timing is important. So a little problem or a little blip where you forget something here or there is expected. But when you really just can't do it day over day and you never fall into a rhythm, that can be a sign that executive function is problematically changing. Language deficits are usually not a big problem in people with Parkinson's. That's usually more with diseases like Alzheimer's, but sometimes in very advanced disease, people might start forgetting words or using the wrong word or non-specific words, making what we call paraphasic errors. Difficulty following conversations can either be processing speed or language problems. And so again, if you notice these are something to definitely bring to the attention of your care team. Now, some people ask me, well, what if I have this tip of the tongue phenomenon where I'm just searching for a word and eventually I find it, but it takes me a little while. Well, that can be part of normal aging, but it can also be part of the executive function that we see in Parkinson's. And that's different than having a true language deficit. Time and place disorientation. So getting lost for, especially in familiar places, is something you want to bring to the attention of your care team. Poor judgment. So this is usually a frontal lobe process, being irresponsible, forgetting appointments, doing things that are out of character, taking risks that are out of proportion to your normal way of, conducting your day-to-day life. All of these things could signal that you need to be evaluated. So, those are the sort of things to watch out for, and that should raise a flag to, that something could be disease related. Now, you may have attended the wellness lecture earlier today, but I want to talk a little bit about wellness too, and more directly how it impacts cognitive function and mood and mental health in Parkinson's. And so first of all, what is wellness? So the definition of wellness is a state of optimal well-being, not just the absence of disease or infirmity. So it's this active pursuit of behaviors and activities that lead to a state of health, whether you have a disease condition or not. So wellness can be pursued whether you have a disease like Parkinson's or cancer, or whether you don't have a diagnosis. And so you adjust to the sort of potential of your current age and health status. And so again, it's a continuum, right? We're always trying to grow. Wellness is about making yourself aware of your health status, educating yourself about what you can do to optimize your health status, whether you have a disease or diagnosis or not, and then growing to reach your optimal potential, okay? And so really there's a sort of foundation of behaviors that are really the most impactful to wellness and your health status. And these really include exercise, diet, and sleep. And then a fourth one that we're increasingly aware of is sort of social connectedness. And so I'm going to talk a little bit about all of those. And then actually in the following days, there's going to be talks on all of these elements. And so this is a little poster from the National Sleep Foundation where they sort of say that, hey, sleep's as important as the other foundational elements of wellness, except for it's only easier, right? Because all you have to do is lay your head on the pillow. And, if only it were that easy. But let's start with exercise and talk about how exercise directly impacts cognition and mental health. So there's different types of exercise. There's aerobic exercise, which is a type of exercise that induces a state of metabolism with oxygen exchange. And this is typically the types of exercise that get your heart rate up, get you breathing hard. There are things like running, biking, swimming, anything that gets your heart rate up, okay? And when we look at this type of exercise in particular, there's been many studies, and I've looked at 18 in particular, where it's improved specific cognitive domains in people who have Parkinson's. And so this is really important because most of the time when we talk about exercise, we talk about its benefit on your physical health. And what I'm showing you here is that this has a direct impact on your cognitive function and mental health. We know that specifically aerobic exercise improves attention, processing speed, reaction time, executive function, and language. Okay. It also has been shown to reduce the severity of depression. Okay. So this is something that is as important to your cognitive and mental health as any of the medications that are currently available in terms of the effect size. We talk about how big of an effect a medication or any intervention has on the symptom of interest. Exercise has effect size that are at least as large as any of the medications that are currently prescribed. And so this is really important because oftentimes people hear this recommendation and they're sort of dismissive. They're like, well, I've always either, I hear two sides. I hear, oh, I've always exercised and I still got the disease, or how big can exercise move the needle? How much can exercise move the needle? And the point is that rigorous scientific study shows that it significantly moves the needle. Now, other types of exercise like mobility, flexibility, yoga, and resistance training have been studied, not to the extent that aerobic exercise has. But let me give you an example. So resistance training, I'm showing here the example of lifting weights, but that can be body weight exercises or bands, anything that sort of produces resistance against gravity and taxes the muscle, okay? And what we know is that in addition to the physical benefits of resistance training, that it also improves performance on measures of executive function and attention, okay, and gait and balance, of course. And so again, I think as more studies on resistance training and flexibility and mobility go forward, we'll see that these are probably, also have a contribution, not just in the physical function of the body, but also in the mental domains as well. Another way to sort of maximize the benefits of exercising, because remember I said another pillar of wellness is social connection, is doing exercise in a group. So, exercise improves all these things, but being in a social context while you're doing this likely has additional benefit. And so, that's a way to sort of double dip, if you will, where you're getting double benefits. Now, I know that there's going to be lectures that talk more about diet, but I do want to say that diet is very important, and we don't necessarily have a Parkinson's specific diet. There's many components of diet that are important to Parkinson's, but right now a diet that is used in a lot of neurological diseases, including diseases like Alzheimer's and Parkinson's, is something called the MIND diet. And really what the MIND diet is a combination of the Mediterranean diet, which is probably the best evidence diet for overall health in everyone, combined with the DASH diet, which is a diet to reduce the risk of conditions that impact brain health negatively, things like high cholesterol, high blood pressure, diabetes. And so the combination of these two diets is called the MIND diet. And you can literally just go online and search MIND diet and find something like this poster that I have on my refrigerator. And it's been shown to probably be the best evidence diet to reduce the risk of diseases like Alzheimer's and Parkinson's that affect cognitive status and vascular changes. Very simple to follow. You can read more about it, but honestly, what's on this poster, if you follow it, is getting 90% of what's required here for this diet. And like I said, there'll be other talks that focus on nutrition and diet and Parkinson's. I do want to talk a little bit about sleep. Sleep is something that I think people really fret about and worry about and have a lot of trouble about because of Parkinson's. And what I always tell people is you want to give yourself an 8-hour sleep opportunity. You're not always going to sleep perfectly. You're not always going to sleep the full 8 hours, but you want to make sure that you give yourself at least this 8-hour opportunity. And there's this concept that we call sleep hygiene. It's a general health concept. So if you look up sleep hygiene, it's things like not getting a lot of screen time before bed, not doing things that get you excited before bed, sort of having a ritual that helps you relax and be calm before bed, not drinking caffeine. And again, sleep is really important for attention and executive tasks. We know that memory stabilization and consolidation probably happen during sleep. So new learning is reinforced by sleep. In fact, we know that if we ask people to learn a list of words and then we give some the opportunity to nap and others not, the people who get the nap tend to recall more of the words. And so again, sleep really plays a role in cognition. It's probably important for brain metabolite clearance. There have been studies of the clearance of amyloid proteins, which is a protein that's involved in Alzheimer's. And we think that people who get good sleep clear more amyloid than people who get poor sleep. In fact, studies have shown that even one night of missed sleep, people clear less amyloid. And so again, this is emerging research, but I think you can see the significance here because Parkinson's is driven by the abnormal accumulation of misfolded proteins, different than amyloid, but might be similarly affected by sleep quality. Sleep is when the gains, both physical and mental, of exercise are realized. And so, again, what we really want to do is get into a good habit of sleep opportunity, okay? Now, let's talk just a little bit in the last 5 minutes here about social isolation and loneliness and just give some definitions. So social isolation is the sort of objective lack of contact or interaction with family and friends in the wider community. These are literally when you're shut in or going out less than you have in the past. So a lot of times if you retire from work, already you're having a decreased social presence, okay? Loneliness, though, can happen even when you're out and about with family and friends. It's more of a subjective, negative feeling associated with a perceived lack of the social network that you idealize, or even the specific connection with a person, okay, a desired companion. And so these two concepts are different but related, and I think important because both have implications. And so here's what we know in general. So I'm going to start with the broad implications of social isolation and loneliness, whether you have Parkinson's or not. So the studies to date have shown that being socially isolated significantly increases your risk of a premature death. And this risk increase rivals the risks that we see from other behaviors like smoking, obesity, and being physically inactive. So just being socially isolated has risks on par to these other things that we know are dangerous. The other really interesting thing is that social isolation has been associated with a 50% increased risk of dementia. So there's something about being connected to others that protects our brain from dementia, whether that's from vascular risks, Parkinson's, or Alzheimer's, okay? Inadequate social relationships are also associated with a 30% increase of heart disease and stroke. And this is in general, not just in Parkinson's. Now, when you look specifically within studies of people who have Parkinson's, we know that emotional well-being is negatively affected from being isolated socially. People are more anxious and depressed and report a higher level of poor well-being when they're isolated. There is an increased reporting of confusion, delusions, and hallucinations in people who are isolated, specifically within Parkinson's. In fact, we know that hallucinations are most likely to occur during periods when people are isolated. Hours of caregiving at home and caregiving burden increase when people are isolated. So again, the whole system is affected when you're isolated. So, I think it's going to be really important to have a proactive strategy to make sure that you're socially connected, okay, as you age, and especially when you have the disease. Now, I do want to talk, and this will be the last slide before we take questions. I do want to talk about things that your sort of care team might prescribe if you have cognitive impairment or dementia related to Parkinson's or any of these Lewy body diseases. And there's really two classes, and I just want to mention them so you've heard them, okay? The first sort of prescribed medication usually is what's called an acetylcholinesterase inhibitor, okay? There's an enzyme that breaks down acetylcholine that we all have, and in these diseases, there's less acetylcholine in the brain. So what we do is we inhibit the breakdown of acetylcholine, and that supports memory and cognition. And so I'm just going to name a few of the available drugs in case you hear about them. There are things like donepezil, which is used originally in Alzheimer's, rivastigmine, which is FDA approved in Parkinson's, and galantamine. All of these can be used in Parkinson's. And basically what they do is increase your brain's already circulating acetylcholine. And this very modestly supports cognitive function as the disease progresses, okay? And for most people, that'll be the first drug offered. As I said, though, it's a very modest benefit. And all of these things that I just said, sleeping the best you can, exercise, and good diet probably are equally impactful and synergize with this medication. So they're on par in terms of effect size. Now, in more severe cases of cognitive change, we might introduce, and some people introduce it early, a drug called memantine. And its mechanism of action is different. It works on the NMDA receptor, and it blocks this channel when it's excessively opened, and it really probably protects the neurons against what we call exocyticity. So when they become hyperexcited, usually by another chemical called glutamate, it blocks that effect. And it's not important for you to remember these mechanisms, but the point is that these drugs can be used together with one another, but also in conjunction with exercise, sleep, and diet to give you the best preservation of cognitive function. Okay, so I want you to know that there's things you can do, but also medications that can be prescribed to help. And then with that, we'll just sort of summarize, the big four things that you can do on your side, and then we'll go ahead and, stop there and take any questions we might have.
Well, thank you, Greg. It's heavy stuff you're presenting, but it's still hope I hear from your presentation as well. Yeah. So I will just remind people that it's still possible to ask questions in the tab, and we will try to sort out that. We have one question here. If you're ready, Greg. Yeah.
Sure.
Good. Yeah. Any thoughts on the role of gut health and the use of probiotics when it comes to mental health?
Yeah, so that's a topic of active research right now. We do know that in Parkinson's in particular, that there's some concern that in some people, the gut may play a role in the initiation of the disease overall. There's a concern about how medications are absorbed and how that's affected by the microbiome. And there's even, some sort of speculation about how this might affect the brain as the disease goes forward. But as of the current time, there's no specific knowledge of how that works, but there certainly is a suspected connection.
Right. And when it comes to doing exercises, you spoke about exercises like direct connected to cognition, like doing crosswords and Sudoku and such things. Is it any help?
Yeah, so there's definitely again active research in sort of brain games and brain training and cognitive rehabilitation applied to diseases like Parkinson's. So that traditionally cognitive rehabilitation is in the area of stroke recovery or traumatic brain injury recovery, but a lot of those concepts are now being brought over to diseases like Alzheimer's and Parkinson's and showing some promise. And so people often ask if brain games or doing the New York Times crossword puzzle might help. And certainly they're probably better than, being idle and not challenging yourself. So I would certainly encourage people to do those, but we don't have specific recommendations at this point. I will say that social interaction is a way to challenge the brain, and certainly, based on the data I showed you, is a protective factor. So I think doing things that challenge you cognitively and interacting socially are two things you can do to actively protect your cognitive function.
Right. Okay, and one more question here. How can care partners play a role in good health for their loved ones with YOPD when they notice cognitive changes?
That's a great point. So this can be challenging because depending on how it's presented, the person suffering the changes could become defensive, right? So, I think it's important to do this in a way that is designed to give perspective about the change that's been noticed. And so, sometimes it's better to sort of do this in the context of the care setting. And then that way the care team can be involved and discuss in a more sort of specific way how cognition has been affected. Because sometimes if you can name the domains that are affected and the ones that are intact, it gives you a better strategy to address the changes. And so the caregiver in many cases is the first person to notice because they spend the most time observing the person with the changes.
And you spoke about depression and YOPD, but how about anxiety as a clinical disorder, kind of? Any comments about that?
Yeah, so I often tell people if you see depression, look for anxiety, and if you see anxiety, look for depression because they're often co-occurring together. And now sometimes you're fortunate in that treating one alleviates the other, but oftentimes you'll treat depression and anxiety will remain, meaning that it might have a different underlying mechanism. And so I always tell people to be proactive about describing their symptoms to their care team so that they can be addressed. And what's important is with both depression and anxiety, it's not just medications, it's oftentimes therapy, cognitive behavioral therapy and other types of talk therapy that can really help address these symptoms.
Right. And we have time for some more questions, I believe here. What is known about the relation of hearing loss and cognitive decline?
So another great point. So what we know from the literature in general, not just within Parkinson's, is that people who are experiencing hearing loss are at an increased risk of dementia. And that even in people who have an identified cognitive impairment, hearing loss sort of compounds the problem. And so oftentimes, one of the first things we'll do when we suspect or even detect mild cognitive impairment is we'll ask people to get visual acuity testing and hearing acuity testing to make sure that those aren't also impinging on their ability to, perform at the highest level they're capable of.
Right. Okay. And how can we find resources for counseling and therapy with therapists that have specific experience working with YOPD patients?
Yeah, so that's a tall order. So in general, there's two strategies that I tell people to use when looking for a mental health practitioner, right? Whether that's a therapist or a social worker or whatnot. And that's to either look on Psychology Today, they have a website, or to call their insurance provider and see which mental health providers take insurance, because that's a good place to start, unless you just want to write a check to somebody, see what's covered by your insurance and see if those providers are appropriately credentialed. The second part of that order is what makes it a tall order, and that's that have experience in young onset PD. And so that's unfortunately a fairly narrow group of people who have expertise in both, mental health issues and in young onset Parkinson's. And so a lot of times a good place to start is with, if you're at a specialty center, oftentimes they have people who've seen a number of people with Parkinson's and young onset Parkinson's.
Right. And one question is about DBS and cognition and mental health issues.
Yeah, that's another interesting topic, because I suspect that deep brain stimulation will continue to be a therapy that's applied to a larger and larger portion of people with Parkinson's at an earlier and earlier time point within the disease as it's refined. And so one of the things that is important is how much and to what extent it might affect cognition, right? Because it's a brain surgery. And so in the majority of cases, it probably doesn't have a significant impact on cognition. In some cases, it might change the trajectory of cognitive decline, and that's something that's still being studied. All of the centers that I'm aware of that do deep brain stimulation surgery for Parkinson's do have a process by which they screen people cognitively to help them understand the risks and benefits, the motor benefit compared to any risk to cognitive function. And I think, as we refine this, not only do I think that deep brain stimulation can help the motor symptoms, I think it's going to be impactful for a broader range of symptoms as we go forward, or at least not impinge on other symptoms. And so, I think what I would tell somebody considering deep brain stimulation is that the cognitive, aspects of the procedure are definitely considered in the major centers that do this operation.
All righty, Greg. I think we are over the top of the hour, actually. Yeah. So I would just say thank you, everyone, for joining us for our session. We hope you found the information valuable. You can download the resources in the resource tab, and all talks have been recorded and will be available for viewing next week. We hope you will share this information with friends or support groups who might like to review these talks on their own time. And again, thank you to Mitsubishi Tanabe Pharma America for supporting this program. And before we sign off completely, we want to invite you to save the date for the 7th World Parkinson Congress that will run from May 24th to 27th in 2026 in Phoenix, Arizona, United States of America. Yeah. And it's just only every 3 years, and the next one promises to be quite amazing. Actually, going to be very amazing. Right. You'll be there, Greg, in Phoenix,
Yes.
hopefully. Yeah, and so will I. And we hope to see you there too. All right. Thank you.